afternoon, everyone. Happy to be with you for this third plenary session on reducing the cancer burden amongst men, which is also entitled, It's More About the Beard this Movember. As you're aware, November is normally the Cancer Awareness Month where men are advised not to shave their beard, and it normally stands on a particular theme. So just to kick us off this session, we'll go through the state of cancer in the WHO Africa region. So as discussed this morning, the Africa region has 1.34 billion people currently, and the total number of new cancer cases is about 1.1 million, and this is each year in Africa. However, the number of deaths is close to 700,000, and out of this 1.34 billion people on the African continent, only 670,000 of them are men. So we have a low men population, and it's almost interesting that we have an equal proportion of men dying from cancer as a total population of men at any given time. In addition, the number of new cases each year is about 475,000 amongst men in the Africa region. And the deaths due to that is about 300,000. And if you're looking at the top cancers in men, you'll have prostate, liver, colorectal, and lung cancer, most of them which have preventable ways that you can prevent these, such as reducing smoking and improving lifestyle choices. And if you're looking now from a business perspective or a financial perspective, the total annual economic cost for cancer is about 1.16 trillion US dollars each year, and this amount is rising gradually due to the increased cases. However, in the Africa region, we only have 35% of public facilities in Africa with pathology services, which is quite interesting given the high investments that are going into managing cancers. And out of the number of low-middle income countries who have access to treatment to cancer, that only stands at 30%, where more than 40 countries which are LMICs are based in Africa. And finally, only 1 in 5 of low-middle income countries are driven by data policy in research, especially with regards to cancer. So it is because of all these facts, we would like to see how EC, government, and how investments and partnerships can reduce our cancer burden. And this is more or less, if you're looking at it from one cancer case, which is prostate cancer, the darker the blue means the higher the prevalence in the region. So you can see it pretty much affects the whole African continent, and it's a huge problem in our region. So without further ado, I think we will be discussing how awareness and prevention, partnerships and development can reduce our cancer burden. And it gives me great pleasure to introduce you to the moderator and the speakers of this particular session, which will have two parts. We will have presentations on various initiatives that are going on with regards to reducing the cancer burden, and then a plenary discussion thereafter. So this session will be moderated by Dr. Daniela Monene, who I hand over to introduce our next speakers for their presentation. Thank you.
Thank you very much, Dr. Marie-Claire, for setting the stage. We have seen some gaps. Data for decision-making is lacking in our part of the world. Pathology services are not adequately spread out. In a country such as ours, they're not only located mostly in Nairobi, but within a certain circumference of Nairobi, the Upper Hill area. So how do we get services to reach everybody? But let me invite our first speaker, who is Dr. Alfred Karabo, the CEO of the National Cancer Institute of Kenya, to just let us know some best practices that he's picked up over the work of NCI Kenya. Thank you very much. Karibu sana, Daktari.
Good afternoon. Thank you for the introduction. I'm happy to be here representing the National Cancer Institute, where we really would want to share our perspectives about what we can do or what we have been trying to do in terms of managing cancer among our men. As an I think as a country, we really have a very good foundation in terms of the legal framework and the policy framework that helps us to think about cancer in general. And for this particular conversation, cancer, among men. And when you look at both the law as it establishes structures like ourselves, the National Cancer Institute, and the law as it speaks to the rights of our patients accessing quality care. Already there's a good foundation talking about elements that have got this conversation. Awareness, early diagnosis, screening, capacity building, ensuring that there's access to quality. They are all these factors that are at the core of what we do, and it's upon this basis that I'll be sharing some of the things that we have picked along as we have gone about conducting or implementing our interventions as an institute. The institute basically has a wide mandate. There are a number of areas that we really focus ourselves on. One critical one is the whole element of policy advisory. I think all these things, we must ensure that at the core of influencing care, our policies are right. So we're also concerned about awareness creation and prevention. We also do quite a bit about enhancing access to care, providing oversight and coordination, data. I think one of the gaps that have been highlighted even as we are setting the stage, the whole issue of, do we have adequate data? Are we doing adequate research in our setting that helps us to understand what are the particular drivers, what are the particular characteristics of cancer within our population, and more specifically within our men, that then can inform our preventive efforts. So we look basing upon those functions. I think at the core of this conversation is the whole idea of awareness creation. And not just awareness creation for the purpose of awareness creation, but awareness creation that influences behavior change towards elements of early detection, early diagnosis. So in our case, I think I have highlighted a number of models that we have used in our programming. We have used community settings. We have had partnerships with the likes of Huduma Kenya. I think one of the things I've highlighted here is what we call Huduma Mashinani, whereby we engage as different government agencies to take services to the community. And one of the services that we provide is actually screening and early detection, so that we drive conversations at that level. And we have actually developed materials that speak even to the person at the lowest level of the community. So you'll even observe within this setting, we have some materials that are in different languages. So we are trying to make sure that our messaging actually speaks to our intended audience. One particular issue that I've not highlighted that maybe some of you may have noticed or may have picked up in the last few days. Since Sunday, the World Cup began on Sunday. And we were very deliberate to make sure that we target the men who are the biggest consumers of the World Cup. So if you are keen, and if you have not been keen, I would challenge you now to hit up for the remaining part of the World Cup. In every match, we're making sure that we have a message board at the beginning of the match, halftime, and at the end of the match. It will have different information, something on prostate cancer, something on cancer in general. So I think those are some of the things that we are trying to leverage on. And really, I have been happy to hear conversations about how do we target men using the things that appeal to them. Anyway, I think the other example, the other best practice that I think we have picked along is the entrenching quality of care within our ecosystem. And we have been very deliberate to work with various agencies particularly with the National Hospital Insurance Fund, make sure that our facilities, our hospitals have the requisite capacity. I think men are very, for just the way men are not easy to go to the hospital, they want to go to a hospital that they are sure provides what, quality to them, what they deem as quality to them. So through these partnerships that we've had with, with the regulatory bodies, we want to make sure that ultimately we have providers of treatment that provide the highest level of quality that would even incentivize, our clients to seek care. So I think that's another critical element that for us we think is important. That not just about access, but access to the highest, quality of care possible. The other thing that I think has been important for us, which would help us even as we think about how do we shape programs, how do we shape interventions around men, is ensuring that we have data. So we have been very keen to build up a system that through which we're able to characterize and be able to get very detailed information on what is the profile like, what is the burden like for cancer in our general population, and more particularly among our men. So that is one of the gaps that I think we picked up along as we as we came in, and what we are geared towards is make sure that we build up a robust system that informs us on what are the more prevalent issues, what are the biggest drivers for for cancer care, for cancer among our men, and through that then we can target our interventions, we can get our research, we can target our awareness, our awareness creation efforts. So ultimately, I think for us, from where we sit, partnerships become very important, because if we are to, scale up the issues of awareness, if you are to scale up the issues of access to care, if you are to scale up the issues of, strengthening the health system so that men can actually access these services, then partnerships become very important. And this, a forum like this for us, we find this as very beneficial. Again, we really need to focus our efforts, really put a lot of investments in the upstream interventions, awareness creation, strengthening the system through, building a more well-endowed workforce. I think those are important points that we see. The whole issue of technology, how do we leverage on technology to make more efficient, more accessible, services for, for our population, and research. I think we realize that as we grow the care for men, as we grow the care for the systems for developing better care for men, then research becomes very important, because we need to understand what are these drivers, what are these critical things that even predispose our populations, and more specifically our men, to developing cancer. And as I said, data for us, I think we also we look at it very, as the foundation that will help us to shape our efforts. I think finally, as I end, I would want maybe to just send out an open invitation to all of us, because these are conversations that need to continue happening. And one of the ways that we're looking at having these conversations is through this summit that we have planned for next year, 2nd to 4th of February. I think a lot of those conversations that have happened in the course of today, cost of care, cultural beliefs and how they affect care, the status of the health system and its ability to to provide care for our population and our men in particular. So all these are areas that we'll be discussing on in this convention. So we'll be happy to to have you in this 3-day summit, and collaboratively then we can move towards changing this narrative. Thank you very much.
Thank you very much. We've heard from National Cancer Institute. Now we'd like to hear the experience and lessons learned from Zambia. So I'd like to welcome on the podium Dr. Jelita Chinyonga, the Director of Performance Improvement at Ministry of Health, Zambia. Please come, Dr. Jelita, and tell us the major achievements, major challenges, and the way forward from a Zambian perspective.
Thank you very much, Daniela. Let me just say all protocols observed. I acknowledge the presence of the First Ladies and the others that are present. So I was asked to give a brief insight of what is happening in Zambia, especially on male cancer. So this is just the presentation outline. I'll give you the country profile, the background, the data on cancers, major achievement, major challenges, and the way forward. So I think most of you know, I don't know if you know where Zambia is, but Zambia is right in Southern Africa. And before we used to say we were landlocked, but now we are saying we are land-linked. We are surrounded by 8 countries. We are surrounded by 8 countries, and the size of the country is 618 square kilometers. The GDP at 2021 was 1,121. This was an increase from 2020. And then we have 18.4 million, that is according to the CSO estimate. So of those, we have 10 provinces in the country. And out of those 10 provinces, we have 2 that are rural, that is Lusaka and the Copperbelt. The rest, that are urban. The rest are mostly rural, and we have 116 districts in the country. So the total fertility rate is 4.7 births. It was higher than that earlier. It was 5.3 at one point, it was 7.3. So when we come to the NCDs, 23% of the deaths in Zambia are due to non-communicable diseases. So this is just the numbers of cancer at a glance. This was, we are getting our data from the Global Cancer Registry. I think you are all aware that we all submit the data. We have a Zambia National Cancer Registry. We submit the data to the Cancer Registry, and it's collected every 2 years. So we looked at 2018 when the population was 17 million. So we had 12,000 new cases, and then we had 7,380 cases due to cancer. This is for all the cancers and the males and the female. So the prevalent cases in that particular year was 24,565. And then in 2020, the population went up. We had over 13,000 new cases, and the deaths were 8,672, and the prevalence in 2020 was 28,556. So you can see that the numbers are actually huge and worrying for us as in Zambia. So now when we look at the males, so we specifically zero down to the males. In 2018, out of a population of 8 million plus, we had 4,825 new cases of cancer amongst males. And in that particular year, we had 3,129 deaths, which is very high. So when you look at what were the leading causes of cancer in 2018, first, like most of the other countries, we had prostate, then we had Kaposi's sarcoma, then we had non-Hodgkin lymphoma, then we had cancer of the esophagus and leukemia. So that was in 2018, and that was our profile, prostate in the males taking the lead. And then in 2020, again, the population was up. We had 5,968 new cases. And then I should also mention that these are the ones that are reported. Some of them are not reported. So some people in the rural areas without access may die due to prostate cancer, but not reported. So we had, again, the top 5, we had the prostate, Kaposi's sarcoma, esophagus, liver, and this time we had colorectum. The next slide. So what has we done as Zambia, as a country? What has been our response? Initially, before we opened the Cancer Diseases Hospital, our patients were going to South Africa, Zimbabwe, and all the other countries. But in 2007, the Cancer Diseases Hospital was opened, and that's when we began radiation therapy. It's got 252 inpatient beds and 80 outpatient beds. And to say that we have people that are coming in now from the other countries to access treatment in Zambia. So in 1982, the Zambia National Cancer Registry was established. And what are we doing? We are having capacity building programs going on, that is locally and for the other countries. And it's also a regional training center. And then the IAEA sends students to Zambia to learn at the Cancer Diseases Hospital. The next slide. So what are the major challenges that we are facing? As everybody mentioned in their presentations, the issue of men, that is the inadequate knowledge and poor health-seeking behavior. We heard, we know that men have this phobia of going to health facilities, so they won't even come to the health facilities when they have a problem. And then we also have the myths and misconceptions. Others won't believe that they'll probably think it's something that it doesn't really happen, it doesn't. So there are all those issues that we have to deal with. And then unfortunately, routine screening is not done. We would have loved to have a situation where we'd screen the men above 45 routinely, but we only do it sometimes on days like when we have the World Cancer Day, we may say, let's screen for prostate as well. And then the late presentation, most of the males will come when it's late and the disease is advanced, so there isn't much that can be done then. Then the Cancer Diseases Hospital, you notice when it was opened, we still have all the equipment that needs to be replaced. And then we also have inadequate diagnostic and treatment facilities. So PSA is only done at some third-level hospitals and not all. And then we have a few private hospitals that are providing PSA. But then what is the access, especially in the rural areas? We don't have private hospital, meaning that access to testing is not enough. So what is the way forward? So we're looking at engaging the private sector in awareness creation, early diagnosis, and early treatment. And then we're also looking at why can't we have point of care testing as we test for sugar, for all the others, diabetes and all the others. Why don't we do it? Why don't we include PSA as well? And then as a team, we need to agree what else, but we are saying that we really need to do more than what we are doing now if we're going to save the men that are already few in number. And thank you very much for your attention.
All right. As Dr. Jolita goes on the stage for a panel discussion, we have heard the gaps. We have also heard from two entities of public sector, but now let us hear from a private sector actor who is redefining cancer care in Africa. So Mr. Ambrose Mutua, I welcome you to make your remarks. Mr. Ambrose is from AstraZeneca. Tell us what you're doing different to bridge the gaps.
Thank you so much, Dr. Daniela Munene. Thank you so much, my predecessors here this evening. You'll be happy that we are also in Zambia, and we'll talk more about that later. My name is Ambrose Mutua. I work with AstraZeneca. AstraZeneca is one of the companies in the cancer space. We have an outfit called Cancer Care Africa, which we are, of course, using to drive some of the projects we are doing in the space of cancer. And we are saying that we need to act for cancer, and that's accelerating change together. As most of the speakers have said, is that we can't do this alone. We have to do this together, and we have to do it with a partnership, framework, and having that in mind as we move forward. We are a global science-led innovation biopharmaceutical company, and we operate in all these countries here as one cluster called the African cluster, all the way from South Africa, Mauritius, all the way to Senegal, Mali, and all these countries. You can see in yellow. We operate in 3 therapeutic areas, broad therapeutic areas: cardiovascular, renal, and metabolism. We also in respiratory and immunology. For respiratory is asthma care. Immunology, you would know us through COVID, for example. And then oncology, of which we are here today to discuss more on. This is Cancer Care Africa. And in Cancer Care Africa, we are looking at 3 main pillars. And I'll just briefly take you through the 3 main pillars. The first one is capability building, whereby we are looking at working with partners to strengthen some of our care centers, push them to centers of excellence through both software and hardware. And then there is also preceptorship and experience sharing from other centers of excellence within Africa. These centers could be even in Northern Africa, in Egypt, they could be in South Africa, they could be existing also in Sub-Saharan Africa. More so, we already have plans of undertaking a virtual academy platform in Kenya with the Ministry of Health and the National Cancer Control Program. And this is to educate HCPs. And this is going to start off in January in collaborations with the various counties in the country. Then we are also looking to expand capacity in 3 main cancer types, that is prostate, breast, lung cancer treatment. The other pillar is about screening and diagnosis, which we are looking at upgrading screening capabilities, and I'll touch on them in the next slide. We are also donating ultrasound needle guided biopsy equipment to major national referral hospitals. I've seen our gentleman here from KU, for example. There's also fostering partnership for targeted testing. And specifically, we are looking at also at this point at EGFR testing capabilities for lung cancer. Lastly, then there is awareness and access to care. We do have social media campaigns to enhance PC awareness. We have an arm called Fight C in Twitter, for example, that talks about cancer. There's also we're also looking at launching targeted therapies. These are innovative molecules that could be now more available in the Western world than here. We are looking at launching them in our continent and in Kenya in particular, and to work with our patient support groups and also together with the other partners who could be governmental and non-governmental in ensuring that they are available and accessible to our cancer patients. Next slide, please. This is an example of the screening that we mentioned on the previous slide. You can see these are vans. So the first one is in Nigeria, free prostate cancer screening. We are working with MedAid Cancer Foundation in Nigeria to do that under Project Icon in Nigeria. And in Kenya, you can see we have got our Middle East Africa leader. She's called Pelin, signing a contract with Dr. Githinji of AMREF. And you can see an AMREF ambulance with a van. And we are hoping that we'll be able to use this to do community screening for certain types of cancers, including, and not limited to cervical, prostate, and so on. Next. This is the virtual training that I'd mentioned, which we signed off with the National Cancer Care Program with, that's Dr. Ahmed's office. And we are hoping that healthcare workers will be able to use this and leverage on it and to upgrade and update their skills through the offering that will be done through this. Next. And we also have our key asks for this forum from our stakeholders that we need, more public-private partnerships to further enhance cancer care in Africa. I don't think anybody will be able to do it alone. We need also continued investments towards cancer care screening and diagnosis in Africa. And mostly needed is public health funding. Especially reimbursement for cancer care is needed. We have our NHIF in Kenya. There are gaps across the continent, and this for prostate cancer, especially for men, when we are talking about Movember, we have a big gap, especially in our peer country like Ghana for prostate cancer funding. So lastly, is that we are working with partners to redefine cancer care in Africa. In this time for us to change the course of cancer care and to act for Africa and with Africa. Thank you.
Thank you very much. Really good to see what AstraZeneca is doing there. So someone just sent me a prompt that they're falling asleep. So please get on your feet. We all need to get up. We all need to get the blood moving. Let's do a short exercise just to awaken our senses before our next speaker. So I wonder if we can spell the word men with our bodies. I wonder if we can manage. So I think we can start with the M. And the M is like this. So you need to make one arm with your one arm and the other arm of the M. And let's see, I'm going to give an award for the best M. All right. Put it a bit higher. Put it flat. Put it a bit lower. Now let's try the E. Marie Claire, can we do the E? How do we do the E? Dr. Akwale, your E is so funny. All right. So I think this can be one of the spokes of the E, then the other arm, and then the leg. Needs to have three. The other side. Like that. Now let's try an N. Let's see, how do we do the N? I think we can write the small n, not the capital. So you just bend until you're a perfect N. All right, so let's do again. Let's do an M. An E. The other side. Perfect N. Jog on the spot. All right, now, don't sit yet. I'm going to give you an instruction to sit, but you do it very slowly. So let's start to sit. Don't reach your chair. Now stop jogging and let's start sitting. Sit, keep sit, don't reach. Sit another 10 seconds. 9, 8, 7, lower, 6, 5, 4, 2, 1. Congratulations. I think now we're a little bit awake, but we need to do a bit more work before we earn our tea break. So let me introduce the next speaker. He is Dr. Isaac Kamau, and he's the Director of Integrated Molecular Imaging Center at the KUTRRH, to just tell us some of the advances they have in the hospital in meeting men's health. Karibu sana, Dr. Kamau. You can speak and then take your seat at the panel.
Good afternoon. Yeah, good afternoon, everyone. All protocols observed. Acknowledge the presence of the First Lady. I've got a few slides. I think I'll just go straight into the slides. A lot has been spoken about this morning about awareness, early detection. So I'll try and not talk so much about that part. I'll focus on those other subjects that have not been spoken about a lot. So the global burden of cancer amongst men is shown in that pie chart. you can see lung cancer is right at the top. This is from WHO and GlobalCan. And then we have prostate cancer coming second. And the subject of this presentation will be on prostate cancer. Colorectal, stomach, liver cancer, they follow in that order. Next slide. So in Kenya, you can see in men, prostate cancer again right at the top, followed by CA esophagus, and the trend continues down. Next slide. So I want us to follow this continuum of care proposed by WHO, matters cancer. So you talk about prevention, detection, diagnosis, treatment, and survivorship. I know a lot has been spoken of. That's the previous one. A lot has been spoken about the first two. So I'll mention them in passing, but I'll focus mostly on diagnosis and treatment, because after diagnosis and after if you miss it at prevention, when you're diagnosed, you need treatment. If it's detected, you need proper diagnosis, so you get better treatment. So they lead into each other. So I'll speak about more on diagnosis and treatment. Next slide. So at KUTRH, we are deliberate about wellness and about men. And as you can see there, we have a wellness package for men. And what we cover there, we cover a lot, but for this specific forum, I just wanted us to mention about what we cover about prostate cancer. So we do PSA for prostate cancer, we do abdominal ultrasound, and also urology consultations. So the focus of my presentation will be diagnosis, precision diagnosis. The picture on your left, there is the Integrated Molecular Imaging Center. It's the first publicly owned molecular imaging in Kenya. So we're talking about, thank you. So we are serving not just Kenyans, but also citizens within the region. I'm talking about Uganda, Tanzania, Congo, Rwanda, all around East and Central Africa. And this facility offers a very unique diagnostic technique for prostate cancer called PSMA PET. So why PSMA PET? PSMA PET is a very specific molecular imaging technique. And this is what makes it specific. Unlike conventional imaging or diagnosis that you would, I'm talking about the MRIs, I talk about CT scans, and any other conventional way of diagnosis. With PSMA PET, it focuses directly onto the prostate. So we inject something into your body, and this is for men, and then the substance that we inject into the body is only absorbed by the prostate and nothing else. So that allows us to definitively stage cancer. We can know the size of the tumor. If it has spread to any other part of the body, through this technique, we'll be able to spot it. So the technique only, the technique works, it follows prostate cancer anywhere they are in the body. I'm trying to keep it in a layman's language. So if you have prostate cancer that has spread to your spinal cord, it will show. So with conventional imaging, sometimes it's a hit and miss. But with this technique, you're 100% sure that you'll be able to find out the stage of the disease. Even within the tumor itself, you'll be able to know what part of the tumor is actually the source of the problem. You can have a big mass, but then which part within that tumor is actually the hot spot? So through this technique, you're able to find out that. And what does it do as a result? You get good diagnosis. It means you get good treatment. Majority of the time, sometimes even the patients we see, some of them come, they're told you have stage 1 disease. But then unfortunately, some of them, we upstage them. We tell them, no, it is not stage 1 disease. It is stage 3 disease. So what that does is that it changes the trajectory of treatment. Sometimes you could have been planned for surgery, but really maybe was not necessary. So very, very important that you get precise diagnosis for your treatment. And also staging also, contributes to, staging, and also for disease that has recurred. And for patients who are already on treatment, at the end of your treatment, you also want to find out all this chemotherapy, hormone therapy, targeted therapy I've gone through, has it worked? So again, here, this is where molecular imaging, PSMA PET, plays a big role. Next slide. I prepared just one slide. I didn't want to be very clinical, but I thought this is quite an important image to show the audience. And you can see in this image, the first one, you can see a hot spot within the prostate. And it's showing you within the prostate itself, there are areas that are hot. So even when you're planning your treatment, you target those areas more than the others. And this is just a different image showing a little bit of spread outside the prostate. So you can see some spread within this area, and also within the iliac bone, the pelvis bone. So conventional imaging would not pick this. So as clinician, we would target to treat just the prostate and then miss out on these other bits that are critically important. And then what happens is we treat you, and then 6 months, 1 year down the line, you're back to us. So molecular imaging is a real game changer for us as a country, but also as a region. Next. So I'll move on to the next, which is precision treatment for prostate cancer. I know we've seen this on the media. That's the cyber knife. I attended a conference, an international conference a few months ago. And when I mentioned that Kenya is getting the first cyber knife in Africa, it's the second one, but Egypt is the first one. They did it a few months ago, but you don't count Egypt as part of Africa. Yes, so the second one in Africa, on a light note. Somebody told me, oh, we need to get more Linux before we go to high technology, get a cyber knife. But I said, yes, it's important that we build conventional radiotherapy machines, we build on that, but also the amount of revenue that we are losing out of Kenyans traveling abroad for these services is too much to imagine. I'll give you a good example. For cyberknife treatment, it costs around 1.5 to 2 million. That's unimaginable. And only a few of us can afford to go. So what that means as a country, that is revenue we are losing. And remember, even when you're traveling abroad, you don't travel alone. You travel with relatives to look after you. You travel with, it's a whole lot of expenditure. And allow me, alongside this one, just to mention on the molecular imaging. NHIF had done a pilot study before we set up the molecular imaging center, and found that as a country, we were spending approximately 8 to 10 billion a year, sending patients outside to India and other countries for treatment. Billion, 8 to 10 billion. After setting up the molecular imaging center, we have scanned approximately just under 3,000 patients in less than a year. if you were to count how much money we have saved as a country, we have saved already above 5 billion. 5 billion. 5 billion. And the two reasons that were highlighted in that study as the main reason why Kenyans were going to India and other countries was the PET scan, the molecular imaging services, the nuclear medicine, and the cyberknife. But then I also pointed out that you can't compare, even if cyberknife is going to save one life, it's more than any money you can count. So we need these services within our border. As I conclude, for the country of 55 million Kenyans, we need some of these services within our borders. COVID taught us a lot, that sometimes you could have even the ability to go outside and seek these services, but at one point we couldn't. With 55 million Kenyans, we need access to these services. So at KUTRH, through the support of the Ministry of Health and the national government, we are currently installing the first cyberknife, second cyberknife in Africa, which is going to be a huge game changer for us and go a long way, especially for management of prostate cancer, which is the subject of today's forum. Allow me to just mention the benefits. With cyberknife, a patient, because cyberknife is often cited as an alternative to surgery. So today, if you need a prostate cancer surgery, you can actually choose to say, no, I don't want the surgeons to go into my body. You can get cyberknife as an alternative with the same clinical outcome. Isn't that great? With surgery, you have to stay in hospital for a few weeks. Maybe you're in a coma. They drive you out, and then now. But with cyberknife, you're able to continue with your life immediately after the sessions. Also, in most men, there's a lot of studies that have been done that with cyberknife treatment, you're able to maintain your sexual activity. With conventional treatment, if there's one very tough discussion we normally have with our patients, is that there is a very high possibility that you will not be functional after the treatment. But now this is new hope for men, because then we can offer you the best treatment while still ensuring that you maintain function for better quality of life, even after treatment. There's also normal urinary and bowel function by 6 months post the procedure. That has been also found for patients who've had a cyberknife as a form of treatment for prostate cancer. And then another crucial one, a lot of our earlier presenters mentioned about men and the need and the link to earning and generating revenue. So conventionally, prostate cancer requires more than 35 days of treatment sessions. So that means that that gentleman will have to close down the shop to some extent, because this requires every single day visit to the hospital. But with cyberknife now, the 39 sessions that you will have come for treatment, you'll have them in 3 or 4 sessions. So that's a huge, huge, huge benefit of cyberknife. Lastly, minimizes radiation that's delivered to bowel and urinary tract system. Again, treatment for prostate can be harsh, and sometimes, depending on the extent of the disease, we are forced to compromise the function of the bowel and other organs that surround the prostate. But with the cyberknife, you're guaranteed that you can treat the disease and spare these organs. Then quality of life definitely is improved. We treat many patients who afterwards start wearing Pampers. And it's not pleasant for a gentleman, for an old man. But now with these modern developments that we have now available within our borders, we are able to give quality treatment and also guarantee quality treatment while we give patients good quality of life. Lastly, allow me just to make my final comments on matters research. I'll echo what even AstraZeneca have mentioned earlier, that as a country, we have been importing guidelines to guide our clinical practices. We need to do research. We need to do research for Africa, in Africa for Africans. What we do mostly is, and then I know we have a lot of documents that guide what we do for prostate cancer, what we do for breast cancer and other diseases. But what do? We pick a little bit of Australia, a little bit of Canada, a little bit of US. But if you look at those population recruited in those studies, they don't cover enough people of our ethnicity to really come and generalize that study in Africa. So I think as a society, we need to be more proactive matters research so that we can do Africa, we can get research for Africa in Africa. Thank you so much.
In Africa, for Africa, I will add by Africans. At least those people that might have thought a cyber knife is a natural knife from the slides, you have seen the picture of the equipment. Now, I'd like to call up our next presenter for this session. And as she comes, please prepare your questions, because after this, we'll pick about 2 or 3 questions to be answered by our panelists. And I'd like our speaker to give us from the perspective of a foundation that's very active in reducing the burden of cancer on the continent. So welcome with me, Her Excellency Mrs. Dorothy Nyong'o. She is the Managing Trustee and Co-founder of the Africa Cancer Foundation.
Good afternoon once again. Having listened to all the presentations today, and in particular this last one, it has given me so much joy because Kenya has come a long way. And I think we need to thank God and applaud ourselves for the strides that we've taken in the field of cancer in this country. When, as Governor Nyong'o shared this morning, when he was diagnosed in 2010 with prostate cancer, and we proceeded to UCSF for his treatment, that was because there was very little happening in terms of cancer care in Kenya. And if all the facilities that we're now talking about were available here then, I am sure that he would have been treated locally. But our experience was that we went to UCSF because, of course, when you are ill, you want the best care, right? We have been accused of running away from the country to look for help elsewhere, but that is neither here nor there. The important thing is that we sought help and we got it, and we thank God that 11 years later, he's still here to tell the story. So while we were at UCSF, we learned a lot. We were plugged into support groups. We attended very many seminars on nutrition, on physical activity. We even had a laughter support group, just for laughing. You go there and you spend 1 hour laughing your silly hat off. Crazy, right? But they say laughter is the best medicine, and there's a reason for that. So they had at Helen Diller, they had a resource center with a lot of materials to read, computers. You could ask questions whenever you needed to. And we had regular meetings with doctors and other people in the space. And as you all know, at the time that he was diagnosed and getting his treatment, he was the Minister for Medical Services. And God really has a sense of humor, because at the same time, his colleague, Beth Mugo, who was the Minister for Health, for Public Health, also had cancer, breast cancer. So here's a situation where two ministers are dealing with cancer. Now, what was happening was that while he was minister, even before his diagnosis, he had tried to introduce very many changes in the health sector, including setting up a comprehensive care center, cancer care center, and so on. NHIF, he had tried to make changes within NHIF, but he was shot down, always shot down by people who had vested interest in maintaining the status quo. And so we realized that actually, if you're going to do anything about making change in this country, we might have to take a different path other than the bureaucratic path, because we realized that at the bureaucratic level, there were too many roadblocks. And we also realized that at our level, here we are, we consider ourselves fairly enlightened, fairly well-traveled, exposed, schooled. And what we discovered was that we knew very little about cancer. So it was a wake-up call for us. We said, if at our level we were this ignorant, what about the poor Mwananchi? Woe unto them. So we decided, of course, you heard about the articles that he wrote in the newspaper. That generated a lot of conversation, and lots of people started seeking care, going in for screening and so on. And when he came back, all the media were on him to do interviews to talk about his experience. The first shock, of course, was that, wow, you've never seen someone at that level open up and talk about this subject. And I really must commend my husband for doing so, because it opened the doors to the conversations that we're having today. So we decided that we would come back and establish a foundation to work from the ground up. So we set up Africa Cancer Foundation on the 12th of July, 2011. And our idea was to go out and talk to people about cancer. While we were doing so, of course, we discovered that the main cancers that were plaguing our people were the reproductive health cancers, breast, cervical, and prostate, and that these are also the cancers that are easiest to screen. So we focused our attention on that. And we started by creating awareness. We developed some fact sheets on cancers. What are they? What are the symptoms? What are the risk factors? What can you do to prevent them? And what do you do once you're diagnosed? So we have 13 fact sheets that we developed out of the National Cancer Institute of the US materials. One is on understanding cancer generally, and then the other 12 are on the specific cancers. We also developed 4 books that help to get families to start to face it when they have a cancer diagnosis. So you're told you have cancer. And you know, our doctors are not even trained to deliver this message gently. It's rough. It's really a shocker. And then you don't, you know, your world sort of goes blank. You don't know what to do next. You have a million questions, but you don't know how or who to ask. And I must again commend Governor Nyong'o because he's one of those rare health-seeking men. Believe you me, he was constantly going for his annual checkups religiously. Every year, he would go for his checkups. But what was happening? Here we have a situation where doctor is testing him, doing PSA. PSA is rising. Doctor sees this, but does not discuss it with the patient. The doctor himself is old school, decides that we watch and wait. It is not until he went to see another doctor, his heart specialist, for his blood pressure issues, that on reviewing his reports, this doctor observes that there is a rather high PSA and says, go for a biopsy. And this is when our world turned upside down. So I was talking about the books. So the books we have, one helps you to deal with that diagnosis, that report, and helps family members to know how to help or what to do or what questions to ask. Because when you're asking questions, you're sitting there with a doctor. If you are the patient, you're not hearing anything. It's coming through one ear and going out through the other. And at the end of it, you are dizzy and you don't know what to do. So we have that book. We have one on diet, you know, eating hints, what to eat, even during treatment, because sometimes there's nausea and so on. How can you circumvent this? And then we have one on radiation therapy and another one on chemotherapy. So we started out by creating awareness, and we have now been in 26 counties, creating awareness and then screening as well. And we've been screening, now we've screened over 30,000 people, men and women. As has been shared before, men are very few showing up. So of the 30,000, only about 10,000 have been men. We also discovered actually that in some areas of Kenya, the cultural practice prevents women from going to the screening camps on their own. They have to get permission from husbands. And in some cases, husbands would actually accompany the women to the screening. So in places like Kericho and Nandi, we found that the men need to be involved even for women's health. In a place like West Pokot, at one time we were screening there, and we had a young woman come for cervical cancer screening, and she came with her husband, who was fairly elderly, and she had some precancerous lesions and was recommended for on-site thermal ablation treatment. Would you believe it that the man refused to have his wife treated just because it meant no sex for 30 days? So even as we're talking about men's health, we realize that involving men is crucial for the health of the entire family. We've actually realized, all of us in this room, as Amit said, we are preaching to the choir, but we've all realized that men are an endangered species, and we actually just need to step up our game. In doing our work at Africa Cancer Foundation, we have done it through partnerships. Because we are not doctors ourselves, right from the beginning, we knew that we had to find partners to do our work. So our partners have been in the private sector, pharmaceuticals, banks, insurance agencies, non-governmental organizations, County First Ladies Association, and the county governments. And I cannot really overemphasize the importance of partnerships. Some of the challenges that we have observed in the field, or some of the questions that have been posed by the men when they do come. One of them is, how do you screen for cancer, for the prostate cancer? They come there, those who dare to come, they come there trembling because they've heard about the digital rectal examination, and they really don't like the thought of that. They also think that the tests may be invasive. So when we tell them that, we really just talk to them and tell them how they can prevent prostate cancer, and that the test is a rapid PSA test, which is a blood test, just a simple prick, then they're more willing to attend it. During the screenings, we also include screening for blood sugar and blood pressure, because as we all know, it's important to address all these issues, including issues of lifestyle. And then we also do check the men for breast cancer, because, and when we talk to them about breast cancer screening, they're shocked and they ask, do men have breasts? And yes, we do find one, maybe 1 in 100 would have an issue, and we then refer them to the health system. The other concern is they want to know if cancer is genetic. And again, we do share with them that some cancers are genetic, some are lifestyle induced. I think that as we talk about men's health, it will be really, really crucial to address the cultural barriers. And I'm really excited about this session because we have started a very difficult conversation. And difficult as it is, I believe that we must take the bull by the horns and that we must continue this conversation. It's important to include and educate the men, and we must work in teams, and we must have multi-sectoral approaches. I really want to take this opportunity to commend AHB for taking this initiative, for being brave enough to do so, even when it may not look bankable. So it's up to us to prove that it is bankable and crucial for our sheer survival. I believe that together we can have a lasting impact on men's health in Africa. And I want to wish you all well. Thank you, and God bless you.
All right. So I had said that we need to write down our questions, think about them. Please do so. But you will ask our panelists your questions when we break for tea in a few minutes. I just want to come back to my panel with this thought. Somebody in the earlier panel said that collaboration is the new competition. And I think for cancer care, for us to move the dial even a little bit, we really need to focus on partnerships. So if you could give us your parting shots in 2 minutes, focusing on the role of partnerships. We've heard from a foundation, we've heard from a public sector institutions, we've heard from private sector. There's also insurance companies. What is the role of partnerships to try and put this burden of cancer down? If we could start from here, 2 minutes.
Thank you. I think the role of partnerships is trying to bring your strengths in the game and acknowledging that you don't have all the strengths necessary to tackle a problem. I look at ourselves as AstraZeneca, we have strength, for example, in innovation, in science, in research. But, you know, the population really that we help to help belongs to, you know, NCI and the MOH and the government. And therefore, it becomes important for them to, for us to work together with the strength that they have, and they are the owners of policy, laws, and all these things that we exist in. And, you know, with that, then we may be able to tackle a very big challenge which none of us would have tackled without each other.
Thank you. For me, the role of partnership is about harnessing the existing resources. We all come, you know, with different strengths. So partnerships then help us to, you know, synergize these efforts so that we probably are able to do more than we're able to do more collectively than they would have done as separate individual elements. So for me, it's more about harnessing, synergizing, and ensuring that we are working towards one one common goal. Thank you.
Thank you. I think the role of partnership, from where I see it, is financing cancer treatment. That is critical. We can do it by either financing the actual treatment itself, or also infrastructure around cancer treatment and other support mechanism needed to treat cancer. The other component of partnership that comes to mind is research. Research, I think, is critical so that we can develop drugs that work for our people, not drugs that has been researched somewhere else. So those partnerships are critical. And yeah, I think I'll leave it at that.
Thank you very much. The role of partnership cannot be overemphasized. We are looking at maximizing the use of the available resources that we have. Government may have the infrastructure, a private sector may have the maybe the resources for bringing in equipment and all those other issues. So I think if we build on the strengths, the strengths that partnership will make us, I think we'll be able to get to where we are in the fight against men's cancer. And the key is prevention. And when you're looking at prevention, you are also partnering with people like at the community. Once they're given knowledge, then they'll be able to spread the information. For us in Zambia, partnership is a guiding principle in our health programs. We have said we cannot do without the partners and we need them. And this also comes from an old, one of the tribes that we have in Zambia is Bemba, and it says, one finger cannot kill lice. So you need 2 fingers to kill lice. Thank you.
Thank you. I think for me, it has been proven over time that working in silos is both expensive and ineffective. And so I believe that together we can achieve more.
Thank you very much. From our distinguished panel, we have heard about advances in cancer treatment on the continent. We have seen it is possible to have cutting-edge technology right here in Africa by Africans. We have also heard about the power of partnership. We need partnerships in financing, in research. We need to partner with communities. And I would say from Her Excellency Dorothy Nyong'o's story, I have picked up that personal stories are more compelling for behavior change than any advice you get from a professional. And we'd like to applaud you for the work you're doing in your foundation and the thousands of people that you've screened so far. We ask you to go back to the drawing book because we want to see that half the screening seekers are men, up from a third. So thank you very much. Let's give a clap to our panel. And I'll ask the panel to just step forward and we'll take a photograph with the moderator.